It gives me a great pleasure to initiate the block by introducing Dr. Patrick Borgen. Dr. Borgen's going to be giving us a talk geared at the future direction of breast cancer. And we're very privileged to have Dr. Borgen in. Pat is a native of the New Orleans region, having grown up in Slidell and Covington, graduated from St. Paul High School. I went to LSU New Orleans Medical School, and then did his general surgery training at Ochsner, did his breast oncology, surgical oncology fellowship at Memorial Sloan Kettering, stayed on there to run as the chief of the breast service line at Memorial Sloan Cancer Center for many years. He was the co-director of the breast cancer management team in the William F. Keck Breast Cancer Research Lab. He then matriculated to Maimonides in Brooklyn, where he became program director for breast and the surgery residency and became surgeon-in-chief. He built the first cancer center in Brooklyn. Brooklyn happens to be the third largest, even though I guess it's like being Sicilian, right? It's not really part of New York. Sicily's not part of Italy. Brooklyn, the third largest city in the country, and serves 3 million people. He's authored close to 300 peer-reviewed publications, and it's an extreme pleasure to introduce Dr. Pat Borgen to speak to you this afternoon.
Thank you, Ralph. Thank you. It is such a pleasure to be here. I like to say that I wish my parents were here to hear that introduction. My father would have been proud, and my mother would have believed it. So thank you very much for getting me the hell out of Brooklyn, New York for about 3 days. At lunch, we had fried shrimp and incredible muffulettas and Zapp's potato chips. Now, those are 3 things that you don't typically see at a meeting in New York. So, Ralph, thank you. And to all of the organizers with CAGLA, I'm really honored to be here. I've enjoyed these 3 days. You're doing such important work, and I'm just proud to be a small part of it. This was the title that I gave my talk, which is almost impossible for me to understand. So I changed it to lots of stuff I got wrong. And Ralph asked me to predict a little bit about where we might be heading in breast cancer. And one of the ways to do that is to look back and say, what boat did we miss? What disease did we really not understand? But these are my disclosures. I do not own stock in any product we'll be talking about or any successful American company, as it turns out. And so those are my disclosures. I want to start with a video, it's 2 minutes, of a young woman who I've been involved with her care for the past 6 years. And so without further ado, let me go to...
From being told 18-year-olds don't get breast cancer to just 3 months later being diagnosed. Being in a hospital gown, having a double mastectomy the day of my senior prom instead of a ball gown dancing the night away. Being told I was cancer-free to just 2 weeks later having a PET scan that confirmed I was actually metastatic. My first chemo treatment being the morning of my high school graduation, but still putting on my red cap and gown later that night to stand on stage with my peers to celebrate that our future is now here. All while in the back of my mind, the daunting question was, do I have one? Shaving my head when my hair started falling out with my mom and brother. Countless times of no evidence of active disease.
Good news, good news, good news, good news, good news, good news.
To progression.
I don't know, you guys talk, come up with a good plan.
We'll talk.
And save my life.
The amazing doctors that have helped save my life that I'm oh so grateful for. Many nights of fear-filled tears, but many, many more of laughter of love. Silly dances to celebrate life. Learning to live when I was told I was going to die.
I'm living my life!
and loving every bit of this beautiful, messy life of mine, despite it all.
Killing some cancer, looking like a transformer.
Exactly where I want to be. Healthy, happy, alive. This right here is my miracle. And I'm gonna keep living this miracle until I'm old and I'm gray.
This is my story.
Please rise up and join me in welcoming the amazing Brittany Beadle. So I've probably seen that about 30 times, and I get emotional every single time. She was literally diagnosed just after her 18th birthday. She saw 3 preeminent docs on the Upper East Side of the country. Almost all 3 said, go home and get your affairs in order. She was denied fertility preservation. Next month is her 10-year anniversary of being cancer-free. She has been treated, yes, thank you. She has received 13 lines of treatment. Her tumors have biologically changed twice. You saw the stereotactic brain radiation that she's had, and she's literally 10 years out and still fighting. So she has taught me a lot about breast cancer and about stealing hope and about making predictions about the future that we have no basis to make. So she is my inspiration. She's still fighting. She still has active disease, but she's living her life. And so this is an optical illusion. And about 6 years ago, my youngest daughter brought this to me and said, Dad, square A and square B are the same shade of gray. And I thought, oh my God, she's taken driver's ed. I've got to increase our insurance premiums because this is not a good thing. She said, no, I'm serious. If you take a box and you connect those two, they're exactly the same shade of gray. But our mind is tricked because of the checkerboard and because of the shadow of the cylinder to believe that they're 2 different shades of gray. These are called heuristics. Heuristics are shortcuts that our brains take that use less energy, and they can lead us down the wrong path. And even if I go back to the first one, this is the same drawing. Your brain is telling you those are 2 different shades of gray. And I'm going to argue this afternoon that we've done this with breast cancer again and again. Now, I would be remiss not to begin by saying we've made tremendous progress. During the first 20 years of my career, the 5-year survival among young women diagnosed with metastatic breast cancer at diagnosis doubled. And since 2000, the survivorship has gone up by 40%. So clearly fantastic progress has been made, and I'm going to finish with a lot of that. But it's also helpful for me to look in my own career, boats that I missed. So this is one of them. I believed in the 1990s that any messaging about breast cancer was good messaging, and that the more we got the word out there, the better it would be for mammography and screening and clinical trial participation. In 1989, a woman created a peach-colored ribbon for survivorship, and eventually the Susan G. Komen Foundation gave ribbons to thousands of women running in their first race in Manhattan. The following year, this woman, Evelyn Lauder, really created the shade of pink that we use today. And through the Estee Lauder Corporation, that year they gave out 1.5 million pink ribbons. And I thought, gee, what could go wrong? This is really great. The next year, Evelyn created the Breast Cancer Research Foundation, which has awarded more than $1.2 billion for breast cancer research in the United States. So we all grew up with pink. This was the Waldorf Astoria in New York when the Pink Ribbon campaign was initiated. I was fortunate enough. It's not my grandson, that's me, sitting there next to Mrs. Lauder. But then Madison Avenue discovered that if you paint something pink and you say, we're going to give a penny to breast cancer research, the products fly off the shelves. And of course, that's called pink washing. And we've all seen pink Campbell's soup and pink boxing gloves. Pink iPad couldn't hurt. But this has gone too far. I had to call my son, who just graduated from Tulane, and ask him what floating beer pong was. Now, he knew a hell of a lot about floating beer pong. In fact, it's the longest conversation we've had in a long time. But somehow buying this pink floating beer pong table says, I support women fighting breast cancer. I'm not sure that's a good thing. In October, if you go to Kentucky Fried Chicken in New York, you get your chicken in a pink I support breast cancer bucket. The William F. Keck laboratory at Sloan that I founded spent 10 years studying the ingredients of fried fatty foods like Kentucky Fried Chicken. And it was very promotional, as nobody would be surprised by that. But when you buy this bucket, it's interesting that you're simultaneously supporting the cause and the cure at the same time by buying this bucket of chicken. Most egregiously, you can get a I Support Breast Cancer 9mm handgun. And these sold so well, that 3 other companies are now making I Support Breast Cancer. I think this is bad. I think we get immune to the color pink. And so to me, pink washing has been really more of a negative than a positive. So one of the biggest things we got wrong in surgery was DCIS. We believed that if you didn't take DCIS out, it was going to become an invasive breast cancer. That DCIS was an obligate precursor, and almost everything we did was to support that theory. This is the landmark NSABP B17 trial in which women who had DCIS removed with clear surgical margins were randomized to get radiation or not. And we saw an astounding cut in half of the local recurrences from 20% to 10%. And in a clinical trial, that's a big deal. And we focused on that reduction from 20 to 10. But we never focused on the fact that 80% of women that didn't get radiation are fine 20 years later, in fact, 25 years later. In the landmark paper written by Bernie Fisher and Norman Woolmark, they said this: we could identify no subset of women who did not benefit from radiation therapy. Now, I just had Norman Woolmark at my Miami breast conference 2 weeks ago, and he said, no, it was misinterpreted. What we said was we knew the subset existed. We couldn't identify them. And yet this led to a standard of care where, for a while, every single patient with DCIS in the United States has been radiated. Now, we've got tools today, and by the way, these are other arguments that most DCIS was not going to become invasive, including autopsy series of young women who died in motor vehicle accidents where the breast tissue was checked, and a third of those women had silent DCIS. We published a retrospective series of 3,000 consecutively treated cases of DCIS. There were 200 patients where we cut across DCIS, leaving some of it in, and nothing else was done. The patient refused surgery, radiation, or endocrine ablative therapy. In that group of patients where we knew we left DCIS, only 20% ever had any breast condition after that. So the evidence has been overwhelming, but nothing has been as compelling as tracking the popularization of mammography, which you see here starting in the late 1980s was when mammograms got traction, and graphing the incidence of DCIS against the popularization of mammography. It's clear. And by the way, when mammograms got better, the incidence of DCIS went up. And so the evidence is clear that there is a reservoir of DCIS that was almost certainly never going to become invasive breast cancer. So the question is how do we identify those? And there's huge research studies going on looking at which DCIS is destined to become invasive cancer and which DCIS was going to be harmless. We have two commercially available assays. The first one in the market was the 12-gene oncotype DCIS assay, which gave us prognosis. Didn't really tell us about treatment effect. This was level 1B evidence. There is and by the way, Exact Sciences, thank you to them. They are a sponsor of the meeting here. The newer platform is from a company called Prelude DX, which is a similar assay, although it includes some clinical parameters. And it is both predictive and prognostic. It actually talks about the effectiveness of radiation in this particular DCIS. There is also a residual risk group that is likely to recur even with radiation therapy. And so we have these two wonderful tools now to help us rationalize the treatment of a condition that may have never harmed our patient. In December at the San Antonio Breast Conference, this trial, which was called COMET, which was run by two of my former fellows, Alastair Thompson from Baylor and Shelley Wong from Duke, where they took women who agreed to be randomized to do nothing, or essentially nothing, versus conventional treatment. So half of the patients got a lumpectomy with or without radiation and endocrine ablative therapy. And the other group got observation. It was okay if they wanted to take estrogen blockade. This trial, you will not be shocked, had trouble accruing. Women said, wait a minute, you're going to flip a coin. So after a long period of time, less than 1,000 women went on the trial. So you had 480 women in each arm. With 2 years of follow-up, some of these women didn't even have their second mammogram yet. They reported that the outcome was the same. The outcome was the same from this COMET trial. And in New York, we are hearing patients who are being told there was a trial, we don't have to do anything for your DCIS. Now, my friend Mark Johnson, who's in the audience, can tell you why Winslow, Arizona is famous. But this is the second important reason. This is called the Barringer Crater, and it was caused by a comet, exactly. A devastating comet hit this town, and some people think it might have participated in the extinction of dinosaurs. So the question is how does this comet affect our practices? And the answer is it shouldn't. It's too small a number of patients. They're too non-homogeneous. The follow-up is way too short. These patients didn't have any genomic profiling. We don't know the good from the bad from the ugly DCIS. There was an inconsistent use of endocrine ablative therapy in the control arm, and the follow-up wasn't even standardized. So it would be foolish to stand up and say, it is medically safe to watch DCIS right now. So that's a really important message because we're hearing it in New York all the time, and I would just caution all of us not to do that. All right, there are at least 6 types of breast cancer. This was what I believe, luminal A and B and basal, and that was pretty foolish also. So this is a paper that you missed because it coincided with the beginning of the COVID pandemic. Researchers from Switzerland took hundreds, more than 300 breast cancers, and they did laser capture microdissection. They lifted cells out of these breast cancers, and they performed 35 biomarkers on every cell from every breast cancer. And the science was extraordinary. And they identified communities, and they identified communication between communities of breast cancer cells. And they saw evolution of these communities. And at the end of the day, they reported just under 90 distinct types of breast cancers. And I think we're getting closer to the real number now. I think this is probably actually closer. So what did we get wrong? Well, my generation of doctors has been famous. I'm not impugning Dr. Soretti at all, But we've been famous at saying, well, I can look down a microscope and I can tell Dr. Maimonides exactly about this breast cancer. I've got that experience. And the fact is you can't. The fact is morphology has nothing to do with biology, almost nothing at all. And I got tired of traveling the country. I was on the Genomic Health Speakers Bureau for a while, arguing that you can't look down a microscope and predict the behavior of a breast cancer. So I created a really stupid game. I'm going to ask Ralph to help me with this. I call this game, Help Your Child Pick Their Prom Date. Now, in your family, people usually marry their prom dates. So you have to pick bachelorette number 1, 2, 3, 4, 5. Genevieve, pick a bachelorette for us. Based on morphology. Number 1. Ralph? 6. 5. Number 5. Okay. Anybody else? 3. Okay, 3. Anybody else in the back there? Mark, which one would you pick? Okay, so those of you that picked number 1, that's Athena Onassis. She is the wealthiest woman on the planet Earth. The other 4 are serial killers. That's breast cancer. How often did we see a patient, and I'm going to go into this in a moment, who we said, you're fine, this was early, we caught it early, and 5 years later they have L5 met. How often do we see that? A lot. And so we've moved, thankfully, from a culture of descriptive morphology, of looking down a microscope and saying, here's what I'm treating, to really doing much more sophisticated analyses. And this is what Dr. Maimonides is going to talk to you about. And I show it only to stress what she will stress. We were commiserating before this talk about how complicated breast cancer has gotten, and it has. And some of it is the 87 subtypes, and some of it is the fact that breast cancer is capable of Darwinian adaptation. And we see it all the time. 20% of the time, when we have progression of metastatic disease, it has changed its spots. HER2 negative becomes HER2 positive. ER negative becomes ER positive. And so Dr. Maimonides will help with this. There were 4 papers at my Miami Breast Conference a few weeks ago, and I'm going to let Dr. Maimonides talk about 2 of them. I want to just touch briefly in the last couple of minutes on class prediction for early-stage breast cancer, which I think is the next hurdle for us. And then finally, I want to just talk about variants of unknown significance in BRCA pathogenic or non-pathogenic mutation carriers. And I'm going to leave the HER2 story and the estrogen story to Genevieve, who will help us with that. So this is a paper that I think is extremely important. This is Laszlo Pustai's group from Yale, who looked at 40 SEER registries over half a century. And he looked at the outcome from breast cancer. And he looked specifically at, if you died of breast cancer, what did you start with? Did you start with stage 4? Or stage 3? Or stage 2? Or stage 1? And he compared 2000, which was really the beginning of targeted therapy, to 2017. And the results were surprising. All of the progress, the substantial progress, happened in stage 3 and stage 4 breast cancer patients. The proportional reduction in risk from stage 1 and stage 2 was pretty minor. So much so that in 2017, 62% of women who died of breast cancer started with a stage 1 and a stage 2 breast cancer. That's never been true in the United States. Now, you can argue, well, we've seen explosive growth. There's just more of them out there. And that's true. I would actually accept that argument. But the fact is that we still are not including the earliest stage patients in trials. And you'll hear about the Natalie trial and the Monarch-E trial. It is much more than just a numbers issue. This is not just we have more stage 1 and stage 2 patients. So this is really a complicated truth, and it means that we need better and more comprehensive risk assessment In those patients who we are telling, oh, thank goodness, you had a stage 1 breast cancer, or you had a single lymph node positive and the odds are overwhelmingly in your favor, they are. Unless you have a really aggressive form of this disease, or a form of this disease that's going to evolve in a way that will harm you. So this is our next big challenge. Finally, to wrap this up, there's nothing more frustrating to our patients who have bad family histories of breast and ovarian cancer than having genetic testing and being told, well, we found something, and it's called a variant of unknown significance. And we don't know if it's good or bad. Likely it's not bad, likely it's going to just be noise, but we need more follow-up to really characterize your VUS. My goodness, these genes are 30 years old. BRCA1 is 30 years old this year. More follow-up was not the answer. So this is a group from the Mayo Clinic that did one of the most clever scientific studies I've seen in my 35 years. They took something called saturation genomic editing, and they coupled it with CRISPR technology. And they created variants of unknown significance using CRISPR. And they took a haploid cell line. A haploid, as you know, a haploid cell line has 1/2 of each chromosome. So there's only one allele of every gene in a haploid cell line. And this cell line happened to rely on BRCA2 to survive. They then inserted over 6,000 variants of unknown significance into these haploid cells. If the cell lived, that was not a pathogenic variant. That's noise. But if the cell died, they could say with confidence, this is a deleterious mutation. Now, Genevieve is going to talk about the Olympia trial and the importance of the use of PARP inhibitors. So this is another group that we've expanded by being able to clearly define a VUS that's either benign or likely benign. And here's what the data looked like. There were 12% of these that were reclassified as pathogenic. That's 12% of patients that Genevieve can help potentially with PARP inhibitors. And so I think this is one of the most important. It's a technical tour de force. You're talking about inserting gene fragments, 7,000 of them, into these cells, and then tracking what happens to the cell. So this is really a beautiful piece of work. So in conclusion, predictions are difficult. Where we're going is hard to see clearly. But what's clear is that this is an enormous, complex family of diseases. Class prediction remains the key, especially in stage 1 and stage 2 breast cancer patients. We are treating DCIS more rationally, there's no question, but it is premature to start observing DCIS without genomic profiling, expression arrays, some way to really figure out what we're watching. The vast majority of progress has been with stage 3 and stage 4 disease. We're watching the replacement of cytotoxic chemotherapy. I'm not suggesting it's going away forever, but what you're going to see from Genevieve's talk is how the future is getting more clear. And it will not be that dose-dense ACT is the answer in the majority of our patients at high risk. And this is a good thing. But this is going to happen a lot faster than the evolution from modified radical mastectomy to breast conservation. That took decades. This is going to happen very quickly, and we are right in the middle of it right now. I won't talk about the immunotherapy, but this is exciting. There are already vaccine trials looking at things like anti-telomerase antibodies in BRCA mutation carriers to try to really intervene in a preventative way. So my final message, I love this meeting. I hope I get invited back. We've got to deepen our relationship with industry. Our medical center is unique in that industry is invited to our tumor boards. The patient information is anonymized. They're not selling anything. But when we need technical advice, they're in the room. I've given talks for companies where the reps weren't allowed in the hospital. when the talk was happening. This is draconian, right? This is a partnership that we have with industry. Our success depends on this. It depends on the marriage of open-minded, clear-thinking clinicians hooked up with the best technology in the world. I want to finish by expressing gratitude to the tens and hundreds of thousands of women who agreed to participate in clinical trials, not only for themselves, but for their daughters and their granddaughters. So with that, I want to thank you very much for inviting me, and I look forward to presenting some cases. Thank you very much.